Yes, ma'am.
Yeah, sorry for the inconvenience.
Manoj sir, you can start.
Sure. Good evening, ladies and gentlemen. Sorry for this technical difficulty. It is all sorted now. A very, very warm welcome to Secrets of Neurology. It's a knowledge feast for all neurologists, and today is episode 11. We all wait for last Friday of every month, and Secrets of Neurology is the reason for the same. Today, ladies and gentlemen, we have presenting Secrets of Neurology with galaxy of experts. We have our patrons, our program director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. Sir, a very warm welcome to both of you. And we also have the presence of prestigious PGIMer Chandigarh team led by Professor Dr. Vivek Lal and Dr. Astha Thakkar, Dr. Sarath, Dr. Abir and Dr. Neeraj. A warm welcome to all of you. As known to all of us, this program is for a period of 1.5 hours. My honor and privilege to introduce the program director. So thank you for leading this for the entire year. Today is the 11th one. Professor Dr. Sudhir Shah, Professor and Head of Department, NHL MMC, SVPI MSR, Ahmedabad. And sir is also Director of Neuroscience at Sterling Hospital, Ahmedabad, author of 6 books in the field of neurology. Because of his contribution to the field of humanity, patients at large and research work, Dr. Sudhir Shah has also been awarded with Padam Shri, and sir is also recipient of prestigious Dr. B.C. Rao Award and many other such prestigious awards. In the equal breath, I would also like to warmly welcome Professor Dr. Lakshmi Narasimhan. Sir is Director and Professor of Institute of Neurology at prestigious Madras Medical College, same institute from where he studied his leading. Sir is recipient of multiple awards, to mention a few. Paltussi Advisor from AN, A.V. Baker's Award for Global Best Teacher, Best Paper Award at AN. Sir has been leading the field of academics by consecutive multiple seminars, multiple publications to Sir's credit. We would really like to thank Dr. Sudhir Shah, and Dr. Lakshmi Narasimhan for bringing this pulse of wisdom in the field of neurology. Over to you, sir.
Thank you. Thank you very much, Dr. Manoj, for those kind words. And I warmly welcome all of you for this wonderful series of webinars, the 11th episode of Secrets of Neurology, Pulse of Wisdom. You know, it's a knowledge feast for all neurologists. Basically, before about 11 months, myself and Dr. Lakshmi, my fond friend, we had a talk and we designed this program. And it was thanks to INTAS Global Cell Division that we could arrange the series of programs. And as you know, this is one of the real wonderful series, and one and all have appreciated. We have got massive feedbacks regarding the success of this program. Now, Dr. Lakshmi is the backbone, and he has been working very hard every time, you know that. Today, we are most fortunate to have one of the premier institute with us, and Dr. Vivek Lal, who is the head of the team, Professor HOD, and my most loving friend. He is heading the whole team. So I will be most happy to introduce the speakers of today. This webinar, although it is designed for neurology students of DM and DNB, let me tell you that lot of practicing neurologists, including senior neurologists, are attending from time to time, and they all are finding it very useful, practical, and of course, knowledge building kind of webinar. So please spread the word and see that maximum people get advantage. We are planning to continue this for 6 months or even more. So for today's case, Dr. Sarath Alati, who is a senior resident from PGIML Chandigarh, that is Postgraduate Institute of Medical Education and Research from Chandigarh, who is presenting the case, and another senior resident, Dr. Abir Gohil, is going to take it further with science demonstration. Next slide, please. Then we have Dr. Neeraj Balani, who is assistant professor. He who is of course MD and DM from the same institute, and his area of interest is movement disorder. His major achievements, he has 14 publications in peer-reviewed national and international journals. He is going to dissect the case further, and then to take it even further, Dr. Astha Thakkar Kapila, who is again the assistant professor, Department of Neurology, Chandigarh. She will be taking it further. She is a MD Medicine, DM Neurology from the same institute, Chandigarh. Her area of interest is neuroimmunology and neuro-ophthalmology. Surprisingly, at this age, she has 65 publications in peer-reviewed national international journals and 10 book chapters. This speaks of volume of the achievement of this primary institute of India. Next, please. And I have most honor and privilege to introduce our loving friend and senior Professor Vivek Lal, who is professor and head PGIML at Chandigarh. He was a former dean and of Baba Farid University of Health Sciences at Punjab. I mean, to talk about this gentleman in a slide is something very, unfortunate and most inappropriate, but still, as there is a time constraint, I will just briefly introduce him. Everybody across India, from Kashmir to Kanyakumari, and from Kutch to Kolkata, everybody knows him. Professor and head of Chandigarh PGIMR is invited chair and faculty teaching course at scientific session at neuro-ophthalmology. What a great honor for 14th World Congress Neurology in Dubai and 23rd World Congress Neurology Kyoto, Japan. Uh, Visiting guest faculty of neurology at University of Oxford, UK, March 16, the honor which very few neurologists of India has ever got. The teaching faculty, Medical Ophthalmology Society, UK, March 2016. Visiting neuro-ophthalmologist, University of Addis Ababa, November 2015. He has a pioneering work in the identification and discovery of ophthalmologic migraine. You know that this entity was very well described by him and his team for the first time, and that was presented in Headache 2009. It is single largest series in world literature on ophthalmologic migraine. More than 200 index publications, chapters in national, international journals and books goes to the credit of Professor Vivek Lal. Is more than 160 publications in national, international journals, peer-reviewed journals, more than 40 book chapters and whatnot. He is considered a very loving and warm teacher. He is adored by many of his students across India who are all spread now. And we have very fond memories of him coming to my place in Ahmedabad and spending time at our institute. And we hope to have more collaboration with him in near future. So over to you, Professor Vivek Lal, to handle the case. Please introduce the first. Uh, would you like to introduce the speaker, or should I ask this first student to start the proceeding?
The first student can start.
Thank you, sir.
Yeah, Sharath.
Excuse me, is my screen visible?
Yes.
Yes, your screen is visible.
Yes, sir, it is visible.
Yes. Good evening, everyone. Good evening, my dear colleagues and respected faculty. I'm privileged to present the case for today's evening, which is an interesting case of headache, visual loss, and hypersomnolence. So, the patient is Mr. SK. He is a 44-year-old gentleman. He is resident of Bilaspur of Himachal Pradesh, and he is an agricultural laborer. So he presented with chief complaints of headache for 5 months, double vision for 3.5 months, diminution of vision for 3.5 months, and increased sleepiness for 3 months. So to start with, his history dates back to 5 months before presentation. That is, he had headache, which was left-sided hemicranial, dull aching in nature, which used to occur daily with a visual analog scale of 4/10, with onset to peak of 2 hours and duration of 6 to 8 hours daily. So this was insidious and gradually progressive. And 1 month into illness, he developed redness in both eyes with sensation of grittiness, which was more pronounced in the left eye than the right eye, and associated with increased lacrimation in both the eyes. So moving further, 1.5 month into illness, he also developed double vision. He used to see 2 images which are horizontally separated, and the double vision was binocular. That is, when he used to see with both eyes open, he used to see 2 images, and when he used to see with one eye open, he used to see only 1 image. This was associated with adduction restriction of left eye movement. That is, when the family members used to see him trying to look to the right side, his left eye would not move completely toward the medial canthus. And this symptom was also followed by left eye eyelid drooping. So this diplopia improved spontaneously over 1 week, but his family members has observed that he could not move his eyes in any direction, and he also developed drooping of both eyelids. That is, now he was not only able to move his eye towards the medial canthus, but he was not able to move his eyes in any of the direction. And he now also developed drooping of both eyelids. Initially, it started with left eyelid. Now he developed drooping of both eyelids. So 1.5 month into illness, at the same time, he also noticed decreased vision in the left eye. So there was onset to peak of 3 weeks for the vision to deteriorate. It was gradually progressive. Initially started with inability to see objects which are more than 10 meters at distance, but gradually progressed to a distance, it gradually progressed to inability to see uh, objects at distance of 1 arm distance in a duration of 3 weeks. The images were diffusely blurred, but not associated with any painful eye movements, color desaturation, micropsia, macropsia, or metamorphopsia or field effects. For these symptoms, he visited a local ophthalmologist where he was prescribed latanoprost eye drops for this complaint. However, documented intraocular pressure was normal at that time. 2 months of illness, his symptoms progressed. He developed increased sleepiness. He was sleeping about 6 to 18 hours daily, and arousing from sleep was found to be difficult by the family members. And however, he did not have a history of food faddism or abnormal behavior at this point of time. So 2.5 months of illness, he didn't find any improvement with the treatment he was receiving. So he visited another physician where he was prescribed eye drops and oral prednisolone in tapering dose over next 1 month. Prednisolone was started at 60 mg and gradually tapered over 1 month to 10 mg and stopped. So after starting steroids, his redness in eyes, grittiness, lacrimation improved by 100%. Headache also improved by 90%. But there was marginal improvement of vision, that is about 10 to 20%. So after 1 week of stopping steroids, his symptoms escalated. He again developed the recurrence of this grittiness, redness, which were resolved previously with steroids. He also developed photophobia and increased lacrimation in both eyes. Followed by this time, he also had puffiness in both eyes. And his diminution of vision also worsened in the left eye, and he also developed diminution of vision in similar manner in right eye. So before steroids, he had only diminution of vision in left eye, which marginally improved, and after steroids, after tapering of steroids, the vision worsened in left eye, and as well now the right eye is also involved. So 4 months of illness, he developed forgetfulness in form of forgetting incidents or conversations happening on the same day, or forgetting if he has taken food or not. But practically he used to sleep most of the time, that is 16 hours. But when he is awake, his family members observed he had the above symptoms. However, he never complained of weakness of limb, any sensory disturbance in the limbs, or bowel bladder disturbance, imbalance while walking, tremors, or limb micronus. He never had seizures or loss of consciousness, no loss of weight or loss of appetite, no diarrhea or pain abdomen, or any fever. Past history, he had significant history of multiple joint pains for the last 3 years, involving both small and large joints of the limb. But however, he never complained of this joint pain association with swelling, redness, or limitation of movements of the joints, or early morning stiffness. For this, he took complementary alternate medication for 2 months with only partial improvement. He used to have intermittent persistent joint pains. However, he never had any tuberculosis or asthma, or he's not epileptic, or he never had any other gastrointestinal symptoms for the last 3 years. So personal history, he is a smoker with smoking index of 525, consumes alcohol occasionally once or twice in a month, and he had history of unprotected sexual intercourse with multiple partners 10 years back. Family history was not significant. So summarizing my history, he is a 44-year-old gentleman with background history of joint pains for the last 3 years, high smoking index, and high risk behavior in form of multiple unprotected sexual intercourse. So he initially had headache, followed by redness of eyes for 1 month of duration of illness, and later developed double vision, which gradually progressed to gaze restriction and bilateral ptosis, and further involved the left eye, further affected the left eye vision, and further consequently started to have hypersomnolence. So at this point of time, he was given prednisolone, and he has improvement in a headache and redness of eyes. So the prednisolone was tapered after 1 month, and when it was tapered, he developed new symptoms in form of memory disturbances and redness of eyes has recurred. And now the diminution of vision has progressed in the left eye and also appeared in the right eye. So generally, starting the examination, general and systemic examination showed normal vitals, BMI of 21 kg per meter square, clubbing of grade 1 in fingers. He never had lymphadenopathy or pallor. He doesn't have synovitis, organomegaly. His genital examination did not reveal any genital ulcers, scrotal swell. So local examination showed bilateral redness of the eyes, and there is bilateral proptosis, which is more pronounced on the right side than the left side. So CNS examination showed higher mental functions with MMSE of 27/30. Frontal lobe functions are normal. This here only abnormality what he had in higher mental function examination was recent memory and new learning abilities were impaired. Rest of the lower functions were normal. Cranial nerve examinations, cranial nerve 1 was normal and cranial nerve 2 examination revealed decreased visual acuity on the right side. We had a best corrected visual acuity of 6/12 on right side and counting finger of 3 meters on left side. Color vision was impaired bilaterally. Pupil size and reaction was normal and he didn't have RAPD. Anterior chamber examination of the eye showed cells suggestive of active vitritis. So this is the fundus picture of the patient where right eye showed temporal pallor and retinal exudates and left eye showed disc hyperemia and retinal exudate. I will be zooming these pictures. If here you can see there are white specks of retinal exudates here, and there is a temporal pallor on the fundus. This is on the right side. On the left side, we can again see these specks of retinal exudates, and there is disc hyperemia. So further cranial nerve examination, 3, 4, 3rd, 4, and 6th cranial examination revealed that there is complete restriction of the movements, both in saccades and pursuits. As we can see, he had bilateral ptosis, he has bilateral ptosis and is completely unable to move his eyes either horizontally or vertically. He has completely frozen eyes. So when we do a VOR in this patient, his horizontal VOR is preserved. The eyes are now moving towards the fixed point. And similarly, in vertical direction also, the vestibulo-ocular reflex is preserved. Yes. So we also found that he had this horizontal pendular nystagmus of the eyes in form of converging and diverging rhythmically. As you can see, the eye is moving towards there are to and fro movements, converging and diverging rhythmically. These movements will be shown to you in detail in further discussion also. And we also found that he had this abnormal facial movements. Kindly observe the left side of the face where there are sudden intermittent muscle twitching. We would discuss this more detail in the further presentation. So after examination, so the remaining examination was not contributing. So rest of the cranial nerves were normal, and motor examination showed power of 5/5. Deep tendon reflexor 3+, but plantar was flexor, and he didn't have any cerebellar signs or extrapyramidal symptoms. So after examination, I have confirmed the findings of redness of eyes and proptosis. Bilateral gaze restriction was present with bilateral ptosis, and I have added in examination the involvement of the retina and optic nerve, and he had preserved VOR suggestive of supranuclear gaze palsy and he had convergent divergent nystagmus with abnormal facial movements. So list of manifestation after we have got after history and examination: headache, redness of eyes, bilateral ptosis, proptosis, and complete gaze palsy, bilateral retinal and optic nerve involvement, convergent and divergent nystagmus with abnormal facial movements, and recent memory loss. So finally summarizing my history and examination, he is a 44-year-old gentleman with 5 months duration of headache, followed by redness of eyes, third cranial nerve palsy, followed by gaze palsy, of bilateral gaze palsy, and bilateral retinal involvement, hypersomnolence, convergent divergent nystagmus with left facial abnormal movements, and recent memory loss. He also, in the background, he also had history of partial response to steroids with background of joint pains, high smoking index, and high risk behavior. So this I conclude my presentation, and I would invite Dr. Abir, who would help us in localization and analyzing this case further.
Is my slides visible?
Yes, they are.
Very good evening to everyone. I would like to thank Dr. Sharath for presenting such a wonderful case. Now I will take forward the discussion by localizing these signs and symptoms. So initially I'll start with the summary. We have a 44-year-old gentleman with a significant past history of high-risk behavior, polyarthralgia, tobacco smoker, has presented to us with an acute to subacute history of a partially steroid responsive disease. Now he presented as 2 episodes. In the first episode, which dates back 5 months, he presented to us with a headache. Now, before localizing the headache, let's go back to some basics. Now, what are the pain sensitive structures? Now, pain sensitive structures classically being in the intracranial part, being the dura near the blood vessels, the arteries of the circle of Willis and the proximal portion, the meningeal arteries, the large veins in the dural venous sinuses, and recently, last year only, after the study by Fontaine et al., the pia mater and the small cerebral vessels have been included as intracranial pain-sensitive structures. The extracranial being the external carotid artery, scalp, neck muscles, including skin, sinuses, and the mucosa. So in our patient, the patient had an initially left side localized headache, which had later turned out to be holocranial, which was dull aching, which seems to be more of a dural inflammation, though at this point, we still cannot rule out a vascular headache. So 1 month into the illness, patient had developed a red eye. Now, how do we approach this red eye? Classically, acute red eye, there are 5 main differentials for the red eye, being it can be localized to the acute conjunctivitis, secondary to episcleritis, scleritis, acute iridocyclitis, or acute angle closure glaucoma. Now, we differentiate these based on the concomitant symptoms which the patient has. So if the patient concomitantly has watering, discharge, I would like to localize it to acute conjunctivitis. At the same time, sclera being rich in the nerves, it will predominantly present as a dull aching pain in the eye, then the redness, and may be manifested by other systemic complaints, maybe having a decreased visual acuity. Acute iridocyclitis and acute angle closure glaucoma, we can safely rule out by the intensity of their presentation, by acute presentation. So in our patient, we had redness of eyes, grittiness and discomfort, increased lacrimation, though there was no discharge, no photophobia, no ocular pain, no itching or burning, and no blurring of vision. So I would like to localize this as a probably episcleritis, since it is just a mild discomfort to mild pain associated with redness of the eye with a normal vision. But 15 days later, the patient develops diplopia in both near as well as far vision, initially to start off with horizontal, associated with initial restriction of adduction in the left eye. Later, the restriction was seen in all the movements with torso of the left eye, later involving both the eyes. It is also associated with almost at the same time blurring of vision, with redness of eyes, with increased lacrimation and grittiness. So how do we approach the diplopia? Now, what are the causes of binocular diplopia? Classically, the binocular diplopia is seen as nuclear, infranuclear, neuromuscular junction, and extraocular muscle. When we talk about supranuclear, our classic teaching tells supranuclear rarely causes diplopia. That also in a rare cases whenever it's associated with either a skew deviation or INO. So I can rule that out. Nuclear, Since the patient had bilateral ptosis, but the patient had only restriction of one side, the monoocular restriction of all the movements. There was no involvement of superior rectus palsy on the other side, on the right hand side. So I can rule out the nuclear cause also. Infranuclear, I would like to keep that still in my mind, and I would like to further localize it in my next slide. A rule of thumb, whenever we have a binocular diplopia, do always rule out a neuromuscular dysfunction. But our patient had neither a fatigability, the patient had constant diplopia with no diurnal variation. It stayed as a monoocular ophthalmoplegia and later also involved the visual blurring, thus telling us the involvement of optic nerve. So we can safely rule out a neuromuscular cause also. Last but not the least, extraocular, direct the orbital muscle involvement. They can be painful, they may be associated with proptosis, and they are associated with congestion, which were all present in our patient. So I would still want to consider the possibility of extraocular. So based on this, my two possibilities still say as intranuclear or the extraocular. Now further going ahead in the intranuclear, now where do we localize them? Now as these tables classically taken from Brazil, we can safely rule out the fascicular involvement because the patient had no concomitant long tract signs. But what about the extraaxial involvement? The location of the lesion can be either in the subarachnoid space, cavernous sinus, superior orbital fissure, or direct in the orbit also. Same goes if we look for the other movements, like other nerves like trochlear nerve. Again, our localization would be either in the cavernous sinus or within the orbit. For abducens, again, it would be either the cavernous sinus or in the orbit. So where does our final localization lie? So if we see from the lateral view of the cavernous sinus, our localization lies at the anterior cavernous sinus, probably extending till the orbital apex, with the involvement of third, fourth, sixth nerve, and also the second nerve causing the visual blurring, with the local congestion being explained by the involvement of the superior and the inferior ophthalmic vein, thus causing the congestion. But the absence of a fifth nerve involvement takes us slightly away from the cavernous sinus, though that's still not a rule. So what is our hypothesis? Our hypothesis being probably the headache started at the left side with the dura on the lateral wall of the cavernous sinus. Then it extends to the lateral wall of the cavernous sinus, initially causing the adduction restriction. Then further involving the whole of the cavernous sinus, thus involving other cranial nerves, as well as involving anteriorly the orbital apex, thus causing the visual blurring. But still the patient had grittiness. Predominant grittiness was the sign, increased lacrimation was the sign. So I would still want to keep the possibility of orbital inflammation with orbital myositis, with episcleritis, though which cannot be really ruled out. So with this substrate, the patient had taken steroids and there was a partial response to steroids, mainly in the eye congestion, lacrimation, and headache. But there was a minimal response in visual symptoms. And patient further developed new symptoms, for example, hypersomnolence. So where do we localize hypersomnolence? It was historically first localized by von Economo in his case study of encephalitis lethargica, where he hypothesized it to be the involvement of ascending reticular system, which starts from the caudal midbrain, further goes up to the thalamus, hypothalamus, and spreads to the diffuse cortex. So whenever we have a hypersomnolence, we always localize it intraaxially to either a midbrain involvement, a thalamic involvement, hypothalamus involvement, or diffuse cortical involvement. But the patient also had a concomitant memory disturbances which the patient developed. So the memory disturbances, especially for the recent episodic memory, it localizes to the Pepys circuit. And where any involvement of the substrates of the Pepys circuit can cause a disruption of the recent memory disturbance. For example, cingulate gyrus, the medial temporal lobe harboring hippocampus and parahippocampal region, or the anterior thalamus, thalamic nuclei. So historically, what is our hypothesis? Finally, a 44-year-old gentleman with a past history of high-risk behavior and polyarthralgias, probably started as a dural inflammation on the left-hand side, further involving the left anterior cavernous sinus and orbital apex, or as an orbital inflammation, which was partially steroid responsive, later involved intraaxial structures like bilateral thalamus or medial temporal lobe and midbrain, and involving the other side after the steroid is tapered to the other side of cavernous sinus or the orbital apex. So when the patient presented to us, this was the examination as already explained by Dr. Sharath. So as we can see, the patient had scleral congestion. Thus, we have already localized it to episcleritis. Patient also had a vitreous cells, which is suggestive of vitritis. And as already shown by Dr. Sharath, patient had retinal exudates and optic disc pallor, which can be both seen in retinitis. So combining the retinitis with vitritis, and not to forget, patient also was taking latanoprost from before. So was there a possibility of episcleritis with the posterior uveitis? Further, as already shown, there was a conjugate gaze palsy for both vertical and horizontal movements involving saccades and pursuits both, with preserved vestibulo-ocular reflex. Now, how do we interpret this? Now, I would like to take everyone's notice into this basic. Now, whenever we have to move our eye for any conjugate eye movements, this is the nuclear center abducens. Now, this is under the control of 3 supranuclear pathways, one through the vestibulo-ocular reflex, one through the smooth pursuits, and one through the saccades. Now, even if one of these is correct, so for example, in our case, the vestibulo-ocular reflex was present, that means that there is a patency of this complex. The patency of nuclear and infranuclear is still maintained. So where do we have the problem? Our pursuits and saccades were absent. So probably the disease lies somewhere in these pathways. And there's only one place at the midbrain reticular system, the mesencephalic reticular formation, which contains a common pathway for the contralateral saccades as well as the pursuits. So thus our possibility of a mesencephalic involvement still stays. What about the vertical saccades? Again, as we can see, for the vertical saccades and the vertical pursuits, the common pathway lies in the posterior commissure as well as in the interstitial nucleus of Cajal. So if both are absent, vertical saccades or pursuits, then again our pathology probably lies in the dorsal midbrain involving the posterior commissure or the interstitial nucleus of Cajal. Then what is the cause of ptosis? The patient had bilateral ptosis. Preserved VOR definitely rules out the element cause for the ptosis. So did this patient have a supranuclear ptosis? The lesion of the right or the bilateral frontoparietal lobes can cause a supranuclear ptosis. But also to notice that there is also a possibility of a periaqueductal gray matter in the midbrain, just dorsal to the oculomotor nucleus, which has a supranuclear control over bilateral LPS. So yes, we have a possibility of involvement of again the same part of the midbrain, that is a dorsal midbrain. So to conclude, we have both the ocular movements, the extraocular movements, as well as the ptosis, which we can safely localize to the dorsal midbrain, causing the supranuclear control of all the movements. Further examination shows, now what do we see here? We see here that there is a rhythmic convergence and a divergence movement, which is probably a 1 hertz, a very rhythmic movement. Now we need to very closely differentiate it from a convergence retraction nystagmus. As we can see, convergence retraction nystagmus probably looks the same, a convergence divergence, but as we can see, the patient also has a Colliers sign. What is Colliers sign? Patient has a constant stimulation of a levator palpebris superioris, thus leading to the lid retraction, which was not there in our patient. So this patient, as we can see, has, again I would like to show, with the convergence retraction nystagmus, patient also has a lid retraction caused by the Colliers sign. Second, in a convergence retraction nystagmus, classically there is a retraction of the eyeball. Retraction of the eyeball goes, the whole eyeball goes inside the orbit, again which was not there in our case. So we need to definitely closely differentiate from the convergence retraction nystagmus. Colliers sign, again classically we can see as the retraction of the upper eyelid. What about the facial movements? Yes, as shown by Dr. Sharath, the patient had the left-sided predominant lower facial rhythmic movements, which was synchronous with the eye movements. If we can see closely, these movements are synchronous with the converging movements. So what are the different possibilities of these movements? Are these hemifacial spasm? Now, mind it, we are seeing it as a rhythmic movements, but by definition, hemifacial spasm are painless, arrhythmic, tonic-clonic spasms mostly involving the orbicularis oculi, not really involving the lower part. So we can rule out a hemifacial spasm. Are these a facial myecemias? No, by definition, facial myecemias are fine, continuous, rippling, undulating movements seen as a bag of worms. So what are they? They are, looks like a facial myoclonus, which are the only rhythmic facial movements, or probably as a facial myarrhythmias, which again are the slow rhythmic movements, which can be localized to the discharges of the spontaneous discharge of the burst cells in the midbrain, further extending into the pons. So what are the final substrates? We have a orbital inflammation syndrome, which probably started at the left-hand side. Then it just involved the episcleritis of the posterior uveitis in the form of vitritis, retinal vasculitis, and optic neuropathy. Then further it went into intraaxial lesion involving the midbrain or bilateral thalamus and the medial temporal lobe. Then further involved the other side also, with a past history of high-risk behavior and a polyarthralgia, which was partially steroid responsive. So this would be our final anatomical substrates. And I would now like to invite Dr. Neeraj to finally discuss about what could be the etiological possibilities for this. Thank you.
Good evening, everyone. So, are my slides visible?
Yes, they are. Dr. Neeraj.
Thank you. So, proceeding from where my colleague left, so what we have till now, we have a orbital inflammatory syndrome. So we can divide the main findings in this patient into four categories. So we have ocular involvement in form of uveitis. We have a convergent divergent nystagmus with facial twitching and supranuclear gaze palsy. We have a hypersomnolence or hypothalamic involvement, impaired short-term memory or Pepys circuit involvement. So initially we will consider separate etiologies for each of them, and then we will integrate. So considering uveitis, so uveitis, so I have included only those causes which are not limited only to eye, and they have systemic manifestations also. So uveitis, the main causes are infections. So those highlighted in yellow, we thought can be present in this patient. So infections, we thought of syphilis and tuberculosis. Then systemic diseases, systemic inflammatory diseases, we thought of Behçet, sarcoidosis, any systemic vasculitis. And masquerade syndromes are very important syndromes. They are the malignancies, they masquerade as uveitis. So intraocular lymphoma can present like uveitis. So now coming on to hypersomnolence. Hypersomnolence has multiple etiologies, but it is non-specific and can occur in any infectious, inflammatory or neoplastic process, especially when hypothalamus or rostral midbrain is involved. So it may not help us in making a differential diagnosis in this patient. So moving on, again, short-term memory loss has multiple etiologies, so may not help in further enlisting the differential diagnosis. Now, this patient was also having supranuclear gaze palsy. So I have considered here the causes of vertical supranuclear gaze palsy, which are limited. And the main among them are neurodegenerative, metabolic, demyelination and tumors, infections, and autoimmune and paraneoplastic encephalitis, especially anti-MAR2, anti-GAD, and anti-Igilon-5. So we considered autoimmune encephalitis as one of the possibilities. Now this patient, we find on examination, he had pendular nystagmus. So causes of acquired pendular nystagmus, they are enlisted, and neurosarcoidosis and Whipple's disease is one of the causes. And for convergent divergent nystagmus, we could find only 3 differentials. They were demyelination, brainstem stroke, and Whipple's disease. So integrating everything, we considered 3 broad categories of diseases in this patient. First one was malignancy associated with the paraneoplastic or associated with the paraneoplastic phenomena, or maybe directly involving the brainstem. Second possibility, we think of non-infectious inflammatory diseases like sarcoidosis, Behçet's, and in infections, whenever we have such a diffuse encephalitis type, a non-specific encephalitis, we have to think of these infections anyways, neurosyphilis, tuberculosis, HIV, and based on these possibilities, we will discuss each possibility individually. What are the points favoring and points against? So intraocular lymphoma or primary CNS lymphoma, the points favoring were the intraocular lymphoma is the most common malignancy to present like uveitis in adults. So only 50% cases have only eye involvement to start with, and they can have cognitive changes at subsequently in 27% of the patient, and lymphomas respond to steroids, as we all know. Points against were that it was a more of a symmetrical disease towards the presentation to us, and there was no focal deficit despite so much involvement of the brainstem. So that may be something odd for the lymphoma. Then again, lymphomas or other malignancies, they are associated with autoimmune or paraneoplastic encephalitis. So anti-HU, anti-RE, anti-MAR2, and CRMP5, they can cause brainstem encephalitis. And again, anti-CV2 is associated with uveitis. And anti-MAR2, anti-GAD, and anti-Igilon-5 can have supranuclear gaze palsies. So we thought of that it can be one of these brainstem encephalitis, and these can predate the neoplasm, as we all know. But odd was it was not falling into a particular named syndrome, that clearly fitting into a encephalitis pattern. So again, we considered non-infectious inflammatory diseases like sarcoidosis. The age of presentation of sarcoidosis is 20 to 45 years, and our patient is of 44 years, so it falls into the age of presentation of neurosarcoidosis. Ocular involvement occurs in 15% of the patients, and in that too, uveitis is the most common symptom. And when in 10% of cases, isolated neurosarcoidosis can occur. And when there is brain involvement, that hypothalamic dysfunction is a common manifestation, including sleep disturbances. And in 20% of patients of neurosarcoidosis, cognitive problems can appear. But the points against were that the sarcoidosis is usually associated with respiratory symptoms in 50 to 80% of cases, but our patient was not having any respiratory complaints. And even when neurological manifestations are there in sarcoidosis, the peripheral facial nerve palsy is the most common manifestation in 20 to 50% of patients. But in our patient, although there was no cranial nerve palsy, but he was having some facial twitchings. Now, Behçet disease, he was having history of joint pains, and 25 to 75% of Behçet disease have uveitis. It can have retinal vasculitis and optic neuritis. And again, Behçet can involve brainstem, causing ophthalmoparesis and cranial neuropathies. But the defining features of Behçet disease, there was no oral or genital ulcers, no history of ulcers in our patient. Again, neurosyphilis we considered because of history of multiple sexual partners. Ocular syphilis can involve any part of the eye, causing uveitis, optic neuritis, or retinal vasculitis. And we all know syphilis can involve brain parenchyma. But points against were the proptosis in syphilis is seen in very limited cases, and steroid responsiveness without treatment for neurosyphilis, it was a partial steroid responsiveness. So that is a bit odd for a neurosyphilis. And CNS tuberculosis, again, we have to consider this being in India, we have to consider the CNS tuberculosis. It can mimic anything, can cause headache, uveitis, and tuberculomas in brainstem and thalamus can cause somnolence and memory disturbances. So points against were such severe involvement, but no choroid tubercles were seen. And without ATT, steroids were given and he responded initially. So these were some odd points. So rheumatoid arthritis and vagus granulomatosis, I will not consider here because the brain involvement without peripheral nervous system involvement is very rare in these disorders. So as we see in our differential diagnosis, Whipple's disease was repeatedly coming in the differential diagnosis, and convergence, divergence, nystagmus etiology. Also, we had Whipple's disease as one of the etiologies. So we considered Whipple's disease as one of the differentials by seeing non-specific arthritis, arthralgia, his uveitis, his optic neuropathy, cognitive dysfunction. They are all described in Whipple's disease. And with convergent, divergent, nystagmus, and facial movements, there was a suspicion of Whipple's disease, but not very strong because it is a very rare entity. Around 1,000 cases are described in literature till now since it was described. And there are, and still rare is the eye involvement. And orbital myositis is described only in 2 to 3 case reports. And our patient was having no gastrointestinal manifestations. So it was not a very high possibility. So keeping these differential diagnoses in mind, we investigated him and we found a normocytic normochromic anemia with ESR of 5 with raised CRP of 30. And he was having hypoproteinemia, mild hypoproteinemia. His TSH was normal, anti-TPO was negative, HIV and serum VDRL and serum TPHA was negative. Serum ACE levels were also normal. We could find ANA 1+ speckled pattern, which could be non-specific. His pathology was negative, his HLA B51 was negative, and ultrasound testis was normal. So after that, his MRI brain was done, and we can see the T2 axial sections, and brain parenchyma is absolutely normal. Gadolinium enhanced T1 section at the level of midbrain is also normal. But what we could find in the MRI was the thickening and enhancement in T1 weighted fat suppressed images, especially lateral rectus muscle, which I have pointed with an arrow. So extraocular muscles were thickened and they were enhancing on contrast when gadolinium was given. So after that, his CSF examination was done, which was showing 45 cells, 51 proteins, and 70 sugars. Malignant cells were done thrice, which were negative. MTV Gene Expert, India Inc., Cryptola, and CSF VDRL was negative. So then we sent to our patient to our ophthalmology colleagues with the hope that they will find something from the eye. They did a fundus fluorescein angiography, and they found a diffuse capillary leakage, which is suggestive of active retinal vasculitis, but they could not help much with the etiology. So vitreous TAP was done, which was acellular, and TB PCR, varicella, and CMV PCR was negative. One thing was there in the vitreous TAP, that IL-6 was pretty much raised. It just gives us information that some inflammation is going on and nothing more than that. So our suspicion of, after normal MRI, our suspicion of brainstem encephalitis further increased, and we did the FDG PET of the patient, and we could find the increased FDG uptake in the dorsal midbrain as pointed by the arrow here. So after the suspicion of brainstem encephalitis, we sent his comprehensive autoimmune and paraneoplastic panel, which was negative. So after these investigations, we further sit down and narrow down our further differential diagnosis. So neurosarcoidosis, such fluid manifestations, but MRI normal, ACE levels normal, no lymphadenopathy anywhere, we could safely roll out. So neurosyphilis, CNS TB, HIV, we have ruled out. Primary CNS lymphoma, again normal MRI and no PET intake except in the midbrain. So at this point we can rule out, but I have not darkened intraocular lymphoma because it is very mischievous and it can escape. Even we can find normal PET and the patient can have recurrent uveitis, and later on we can find an intraocular lymphoma. And other differentials we remained still paraneoplastic brainstem encephalitis, some undifferentiated syndrome, or then we left with the Whipple's disease after ruling out these causes. So whenever we are in doubt, we visit the patient history and examination again. And I know this video has been, you have seen already, but I want you to see. I will let the video run initially so that it can be, eye movements can be seen easily. So there are eye movements, converging and diverging eye movements, which are around 1 Hz in frequency, along with these facial movements. So if you notice, these facial movements are synchronous with the converging movement of the eye. And along with facial, some chin movements are also occurring. So this is, after seeing this, we thought this to be oculomasticatory myarrhythmia. And we did an investigation. We did his UGI endoscopy and duodenal biopsy was done, which showed macrophage infiltration into the lamina propria pointed by the arrow. And in this slide, in 200 magnification, 200 times magnification, this is a PAS staining. We can see PAS positive macrophages further magnifying. So these are PAS positive macrophages, foamy macrophages, which are called, showing PAS positive intracellular rod-shaped organism suggestive of Whipple's disease. So to diagnose a definite CNS Whipple's disease, we must have any one of the following criteria. So our patient was having oculomasticatory myarrhythmia. So we need not to have other positive things, but we did we proved in the intestine that he was suffering from Whipple's disease. We did it was histopathology was positive. So our patient was having definite CNS Whipple's disease. So based on this final diagnosis, we kept possibility of Whipple's disease. He was treated with injection ceftriaxone for 2 weeks, followed by, first we started him on Septran, but he developed allergy to that, and he was subsequently shifted to hydroxychloroquine and doxycycline. And what is more rewarding than seeing your patient improve in front of your eyes, this is just after 4 weeks of treatment. We can see, we are very grateful for the patient and his family to send this video on a short notice. We can see his movements have decreased, although they are present, they are very, the amplitude is very small and they are occurring rarely. So this was all from my side. Thank you for your patient listening. Now I invite Dr. Astha to further teach us about the Whipple's disease.
Many thanks, Dr. Neeraj. Many thanks to Professor Lal, Professor Sudhir Shah, and Professor Lakshmi for having us here. I would, so now this was the journey of this patient from having visual symptoms, headache, and from having some memory disturbances and hypersomnolence to his final diagnosis of Whipple's disease. So what I would like to say over here is that when everything is given one by one, it is easy to diagnose a patient. But what when the patient first presents to us? So, sorry. I hope the slides are visible. I hope the slides are visible.
Yes, when they are visible.
Thank you.
Absolutely.
So, but what if the patient first presents to us? When should one suspect Whipple's disease? So I'll take you through it. What is Whipple's disease and what is Neuro-Whipple's, and when to suspect and when not to suspect as well. So Whipple's disease is a relapsing, multisystemic, chronic infectious illness, which is characterized by migratory polyarthralgias, chronic diarrhea, and fever of unknown origin. As Dr. Neeraj very classically mentioned, that there are only a handful of cases which have been described despite its being recognized many, many years back, centuries back. It occurs more in Caucasian population, and it is again one of the rare diseases, maybe let me say other than Behçet's disease, to be more common in males as compared to females. Average age of occurrence is around 50 years, and it has been thought that a possible fecal-oral route of transmission occurs because of its more occurrence in farmers, people with soil and animal exposure. The genetic predisposition is highly controversial because it's seen that patients of the same family, patients who are having same environmental structure as well, go on to develop Whipple's disease in clusters. So whether it is genetic, whether it is all environmental, it's difficult to say at the given juncture. So Whipple's disease was originally called lipodystrophy intestinalis, and the name has been given by George Hoyt Whipple, who initially described this disease to be a fatal disease, to be associated with severe weight loss, fever, maybe cough in some patients, and to be specifically having unsplit fat, specifically again in intestinal mucosa. Rod-shaped organisms were recognized in this disease, but it took around 85 years to understand the genomic sequencing and strain identification of what was causing Whipple's disease. So this disorder, which was initially only considered to be an obscure disturbance of fat metabolism, was considered infectious in early 1950s when the first patient was treated successfully with chloramphenicol. Subsequently, it took many years again, around 40 years, for it to be diagnosed and to be named as Tropherema whippleyi, derived from the Greek word trophy meaning barrier, erema meaning nourishment, and together it means barrier to the nourishment. It belongs to gram-positive actinomyces, and as I told, it took around 85 years for it to be sequenced and strained to be identified before we called it Tropherema whippleyi. So before I move further, very, very quick introduction of how Whipple's disease cause its pathophysiology inside one's body. Humans are considered the only host. Initially, the infection enters, colonizes itself, and very interestingly, it causes lots and lots of macrophage recruitment. The cells die. Further on leads on to dissemination based upon cytokine-mediated mechanism. So maybe this is what is Whipple's disease: infection plus some immune mediation inside the body, which makes it to spread to other organs, even to brain, and hence causing an immune-mediated damage, along with the damage caused by direct invasion. And what we classically see is a macroscopic appearance of dilated villi, of ectatic lymphatic vessels, and extensive macrophages infiltration, which are at times even visible on duodenoscopy or endoscopy. Microscopically, lots and lots of lipid deposits, large foamy macrophages, as is mentioned over here, pass positive staining these macrophages, loss of microvilli, and if we are lucky, we can also see the bacillary debris. So what is the clinical scenario? As I was mentioning, these patients classically present with GI symptoms. Around 90% of patients would present with some sort of a diarrhea, long-standing abdominal pain, weight loss, maybe steatorrhea and malabsorption signs as well. And many of them do have systemic signs like arthralgias, anemia, low-grade fever running together for years, lymphadenopathy, and maybe hyperpigmentation. CNS is classically involved less. Only 20 to 30% patients develop CNS manifestations, and ocular are even less, around 15% of patients. So why I've put this slide over here is to again take your notice to these systemic signs which may precede around 8 years before manifesting Whipple's disease in per se, in systemically or maybe even GI manifestations. They may take around 8 years to develop. And this is why the other differentials crop up. So the patients have often been thought to be having sarcoidosis, syphilis, vasculitis, even Behçet's disease, lymphomas, only because of these lurking symptoms which occur for years together. And often they are missed. They are not even treated properly many a times. So why Whipple's disease of CNS? How does Whipple reach the brain? So as I was talking, Whipple's disease reaches the brain either through direct invasion or it causes a bacterial inflammatory response. The point to be noted is that Whipple's disease of the CNS is the most serious manifestation of Whipple's disease, and it may even lead on to irreversible damage. If untreated, it may lead on to a very high mortality and has been described in various case series and case reports. Death can be seen in as early as 1 month period if it is left untreated. Rarely, it can be the first manifestation. Interesting to note that 15% do not develop GI symptoms and remain localized to the CNS. So broadly, you can consider it as primary CNS Whipples and secondary CNS Whipples. 30% of patients with advanced GI symptoms can present with CNS relapse as well. Just to give you a vague example, now this 46 years old female in this case report presented with progressive epilepsy, diplopia, ataxia, and saccadic abnormality and hyponatremia of 4 months duration, and subsequently went on to develop hyperamnesic syndrome. And what we see in the MRI brain is these T2-weighted hyperintensities of mesial temporal lobe, some hyperintensities in basal ganglia, hypothalamus, mammillary bodies, periaqueductal gray matter, and some mild contrast enhancement. This patient tested positive for Whipple's in CSF. CSF was also having high cells and high proteins, but the body screening was normal. So this Whipple's disease could not be demonstrated in any other tissue than CNS. This is primary isolated CNS Whipple's. Now this is in contrast to this next example. 41 years old male presenting again with abrupt onset facial twitching, blurred vision, ataxia, hypersomnolence, and with gaze restriction. Now this patient's MRI was normal. CSF was essentially normal. However, PCR was positive for Trophirma whippleyi. But this patient had CT abdomen, which was showing lots and lots of lymph nodes. And finally, the PAS staining and the PCR in lymph nodes also showed a positive result for Trophirma whippleyi. This considers, this makes this patient to be having a secondary Whipple's disease, causing CNS disease secondarily. However, in this case, it was preceding the CNS manifestation was preceding the systemic Whipple's. Another way of broadly considering Whipple's of CNS is to divide it symptomatically. So patients can have a multifarious neurological syndrome whereby multiple CNS symptoms can come together, or the patients can just have a focal limited neurological deficit. The diagnostic symptoms, the symptomatology varies from affection of cognition to UMN disturbances, to cerebellar gait disturbances, to gaze disturbances, even to sensory manifestations and to epilepsy as well. Now, just broadly classifying these patients can have cognitive disturbances. A point to be noted over here, many a times these patients are treated as unclassifiable encephalitis, somewhere akin to autoimmune encephalitis. The patients can have any symptom depending upon where affection is there. So if hypothalamic involvement is there, patient will present with hypersomnia, temporal memory loss, frontal typical frontal syndrome, and so on. The patients can have multiple movement disorders. They can have extrapyramidal symptoms, myoclonus, and as has been specifically mentioned also by Dr. Neeraj, oculomasticatory myarrhythmia, oculofacial skeletal myarrhythmia are pathognomonic for Whipple's disease. Patients can have cerebellar signs, upper motor neuron signs, and rarely can develop meningitis, involvement of the hypothalamus pituitary axis, and also these patients can rarely have labyrinthine involvement as well. So specific mention of neuroophthalmic manifestations, as was seen in this example. Now this particular case report, which was reported by Dr. Lee, had supranuclear ophthalmoplegia, and after seeing the MRI, which was suggestive of hyperintensities localized to midbrain and negative other investigation, patient's PCR was done from CSF, which was seen to be positive for Trophirma whippleyi. So patients can just present with supranuclear ophthalmoplegia and convergent divergent nystagmus. The convergent divergent pendular nystagmus is another characteristic feature of Whipple's disease. Why? Because this is the area of involvement, the midbrain, the periaqueductal gray matter, and this is where the convergence or the vergent centers lie, and hence causing a typical convergent divergent pendular nystagmus. Novel eye movements have been described in Whipple's like staircase horizontal saccades. Putting it simple, involvement of both horizontal as well as the vertical saccades, leading on to this staircase type of movement, gaze evoked nystagmus, and on primary gaze, esotropia, again due to the involvement of the virgin centers in Whipple's disease. So as I mentioned some time back, and as was mentioned by Dr. Neeraj, diagnostic guidelines have oculomasticatory myorrhythmia and oculofacial skeletal myorrhythmia as one of the core diagnostic clinical marker, which can be used even without biopsy or PCR. So as was showed in this patient, the patient was having a convergent divergent nystagmus synchronous with the facial movements, right? So this is not the classical variety of oculomasticatory myorrhythmia, rather the other patient which I've taken from literature shows masticatory movements along with this convergent divergent nystagmus, which is again pathognomic of this disease, which we call Whipple's disease. So I move on further. Why I've covered ocular Whipple's disease is because our patient did have these manifestations if we see properly. So the patient had retinal exudates as is seen in this fundus picture. The vitreous haze is a common manifestation, and these cotton wool spots in these patients should be looked into. These manifestations are very rare when they are occurring without CNS or GI involvement. Another involvement, as was mentioned some time back by my colleague, that recurrent orbital inflammation, specifically orbital myositis, is even rarer representation, though case reports are available in literature. Another interesting finding which I studied while looking for the literature was a patient who presented only with arthralgia and chronic papilledema, along with, of course, peripapillary hemorrhages. And the patient was worked up again and again and again. As you notice over here, this is a case report dating back to 1969. So at that time, the patient, when he presented with the second manifestation of bacterial endocarditis, went on to develop confusion, and the patient finally succumbed to his illness. Was that autopsy was done of this patient. And interestingly, both the jejunum as well as optic nerve showed these intracellular pars positive material, and now retrospectively was having a Whipple's disease. So revisiting, when the question is, could it be Whipple's? And we are getting an answer to this question as neurological disease occurring with myoclonus, dementia, and supranuclear ophthalmoplegia, along with some unexplained symptoms of uveitis, systemic symptoms. Do think of Whipple's as one of the diagnoses. Diagnosis delay is around a period of 2 years. A short note on the MR imaging. So though we see T2 flare hyperintensities in this given localized area, periaqueductal gray area, temporal lobes, midbrain, hypothalamus, thalamus, it is interesting to note that the patients do not have diffusion restriction and only a minimal enhancement is seen. So while we have seen these in the previous examples, just highlighting the T2 flare hyperintensities in temporal lobe, hypothalamus, again, minimal enhancement, now midbrain involvement, mild cerebellar involvement, periaqueductal gray matter involvement without diffusion restriction, think of Whipple's disease again. To be very sure, demonstrate foamy macrophages on PAS staining, PAS periodic SSKIF, as you all know, or show nucleotide sequence by amplifying by PCR, show antibody by immunohistochemistry, or cultivate the organism. So this is how we go. So if we see these foamy macrophages on PAS staining, it is one of the definitive diagnoses of Whipple's making. Do remember that false positive reports can be seen in polyglucosan bodies, prions, and glycogen. So unless you have a clinical support, we cannot just depend upon PAS staining, and hence we say that more than one modality of diagnostic thing should be done before we say a patient to be having a definitive Whipple's disease. So PCR, as I mentioned, has a very, very high sensitivity and can also be present in healthy carriers. And it is also very highly prone to environmental conditions and the patients can have multiple text positivity. So this should not be used isolatedly as a screening tool. Immunohistochemistry, this is how it looks like. Again, patients who are having positive PAS screening can have positive immunohistochemistry as well. So cultivation has only been done in specialized research laboratories, not very avidly available. Non-specific markers can give us support, like markers of malabsorption, high ESR CRP, fat malabsorption, and CSF showing specifically high OCB, suggestive of high antibody synthesis. So diagnostic guidelines of CNS Whipple's only go through them when the clinical scenario is supportive. As I mentioned, oculomasticatory myorrhythmia and oculofacial skeletal myorrhythmia can be used isolatedly for diagnosis, Otherwise, we depend upon tissue biopsy or positive PCR analysis. So this is the thing which you will get recently in literature. This is the latest practice guidelines which say that in case you are suspecting a patient to be having Whipple's disease, first do a duodenoscopy, at least take more than 5 biopsy, prove past positive macrophages, and further make sure of that the patient is having either positive PCR or immunohistochemistry. And case it is not there, rely upon alternative effective tissue sampling, which means show that there is a positive PCR or past staining in CSF, lymph nodes, synovial fluid, and so on to make a definitive diagnosis of Whipple's. Quickly, I move on to management. So all what we have is only a retrospective analysis of small series to tell us whatever is the practice guideline for Whipple's. And this is what we have in total, that initial treatment of 2 weeks with ceftriaxone, meropenem, followed by indefinitive treatment with trimethoprim sulfamethoxazole. In case a patient is allergic, doxycycline, hydroxychloroquine can be used. Do remember that though these drugs are bactericidal, they do not cross blood-brain barrier. Hence, effectively, they are only acting on systemic Whipple's and not causing any benefit for CNS Whipple's, and hence is a cause of CNS relapses, and hence needs a great follow-up of these patients. So follow-up of these patients at least 2 weeks. Investigations should be repeated 6 months, 12 months, and then annually. And it has to be remembered that a few cerebral symptoms can just be irreversible and not fully resolved. So this is the latest research which is available. It's still not published. It's still non-randomized. And it shows, I mean, like the people are studying effect of meropenem versus ceftriaxone. People are also studying whether trimethoprim and sulfamethoxazole can be given only for a period of 1 year isolatedly. Duration of therapy ideally should be indefinitive. Reduced host T helper cell response as in this is one of the factors which may tell us indirectly that corticosteroids and immune therapy can actually act in these patients. And one example was also seen in these patients that the patient did have some mild corticosteroid responsiveness in the early stage of the disease. So role of interferon gamma has also been brought up and again not proven. So from here, I just end this thing by just giving you 4 take-home messages. Whipple's disease of CNS is rare. It is potentially fatal. History is the biggest clue. Revisit for specific issues, specifically to look in for the myorrhythmia, which we were talking from the beginning of the presentation. Footprints can be there for a long period of time. Patient can give systemic signs which have been present for a very long period of time. And management intricacies, choose a drug which crosses CNS preferably. Thank you. I request Professor Lal sir to kindly take over from here. Sir?
So I think, are you hearing me?
Yes, sir. You are.
Yes, sir.
Dr. Sudhir Shah, are you hearing me?
Yes, sir. Yes, sir.
Dr. Sudhir Shah?
Yes, sir. We're all there.
You're all there. No, I'm specifically addressing this to Sudhir Shah. Is Sudhir Shah around?
Yeah, he's there.
I am here, sir. I am all the way here.
Sudhir Shah, if you remember, एक पृथ्वीराज कपूर की मूवी थी कल, आज और कल.
सही बात है.
ठीक है, उसमें वो कहता है अब हम पुराने हो गए. तो इस केस को देख के मेरे को लगता है अब हम पुराने हो गए. At least I did not get the answer right. I was nowhere near the diagnosis. I discussed this case, and ये बदमाश मेरी जो टीम है चुप करके इन्होंने बायोप्सी कराई, मेरे को कुछ नहीं बताया, and 2 days later एक फौजी खड़ा कर दिया मेरे आगे, सर वो तो Whipple's निकला है. I'm so happy they got the diagnosis right. Astha made a comment कि the average time taken to come to a diagnosis is 2 years. हमारे यहाँ in less than 2 weeks we got the right diagnosis. The patient came to us. In 2 weeks, we had the diagnosis in front of us. Everything was deceptive. Everything was deceptive. The patient had orbital myositis. The patient had visual involvement. The patient had almost everything to take us away from Whipple's. But there was one thing which he had, which I diagnosed, but I did not think of Whipple's, was that oculomasticatory myorrhythmia. I felt it's a brainstem myoclonus. I could see the ocular muscles move, and I could see the facial muscles move, but it was eventually an oculomasticatory myoclonus. So the moral of the story is, if you get OMM, no matter what the presentation, I think you should always think of Whipple's. and I give credit to this team. अब हम पुराने हो गए हैं, Dr. Sudhir Shah, हम साथ बैठेंगे, that they got the diagnosis bang on. It's an exceptionally good case. I have not seen something like this, totally deceptive. And now the other point is that orbital myositis has been reported as such. Whipple's not more than 1,000 cases have been reported. Orbital myositis has been reported in less than 5 cases. Though if this case is accepted for publication, this will probably be the 6th case where the presentation was orbital myositis. You see, the presentation was an orbital inflammatory syndrome. And when you have an orbital inflammatory syndrome, in the background of, polyarthralgias and polyarthritis, you think in terms of Wegener's, you think in terms of rheumatoid. But again, the clue was that OMM, that they got right and they made a terrific diagnosis. Credit to this team, all credit to this team of young, brilliant people. And I'm very happy to have got it right for tonight. It's a fantastic case. Thank you very much. Thank you very much.
Sir, if I may say, it is your training in the departmental training. There is a story of Einstein. वो बोलता है कि उसका ड्राइवर भी जाके लेक्चर दे सकता है, तो आपकी तो टीम भी डायग्नोसिस कर सकती है सर.
I mean, sir, this case, I tell you, the video has not come out well. That's the unfortunate part. That nystagmus retraction, convergence, it is something which is worth seeing, and the facial movement is worth seeing. And the other thing which is the follow-up, there is a dramatic recovery on follow-up. Astha, the recovery is fabulous. Yes, and sir. That Abhir did not show me till I saw it now. Definitely that nystagmus has gone away. And I think that facial, that facial movement has totally vanished. So a proof of a pudding is in its eating. This is actually Whipple's and nothing else. And this is biopsy proven. I've gone and checked the slides, and there are past positive macrophages. We didn't do the PCR. I don't think we did the PCR in this case. Did we do PCR?
PCR was not available anywhere.
Yes, so we have not done the PCR, but the past positive macrophages are floridly present. They are floridly present, so we've got the diagnosis right. And I just saw that Dhananjay is an alumnus of PGI. Dhananjay had thought of Whipple's. Dhananjay, I don't know how you got it right. You always get things right. That's right. This is Whipple's and nothing else. Thank you ever so much. And I was just seeing the number of attendees is more than 200. It's been gradually increasing till the end. So that's something to really be encouraged about. Thank you once again.
Sir, there is something more to it. You are now internationally renowned. Today we have people from Canada, Spain, London, and all nearby countries, right from Sri Lanka, Malaysia.
The comment who's lucky to be here in this session is from at least 10 to 15, more than 20 abroad people are there, sir.
Yes.
Yeah, that's
yes,
what
thank
I'm
you.
saying.
Yeah, there's someone thanking us from Pakistan.
Mr. Arunjata, how much is attendance, total attendance?
230.
Huh?
29. Sir, it's around 300.
300, okay.
300 is very good at this time of the day. I mean, that's very good.
But I must tell you, this is one of the best cases that we had in the series.
Yes.
In the 11, I think this is one of the best, if not the
We are really happy. We are thankful to you, sir, that you gave us a chance to present this case. We are really thankful.
The pleasure is entirely ours, and your team requires to be saluted. So really wonderful.
Credit to the team. I mean, I think Astha and company, Astha, Neeraj, and all the residents. I mean, this is a fabulous case. It's a case which will remind you, which I will remind myself again and again. You know.
Yes, sir.
So thank you.
Thank you, sir.
Sir, I have one question. Did you give steroids thereafter, or you just gave on? Because I missed that part.
No, this steroids were given in the beginning by an outsider. I think now we have just given ceftriaxone, na?
Yes, sir. We have given
only ceftriaxone. I repeat, now he has gone home on ceftriaxone, and the recovery, the dramatic turnaround is on ceftriaxone.
Very.
Yes.
Sir? So, Dr. Lakshmi, would you like to announce for the next meeting?
Sir, shall I? Sir, shall I?
Please.
Yes, sir. Sir, first of all, my hearty congratulations for a wonderful session by the supreme team from PGI Chandigarh, headed by Professor Vivek Lal. And as all of you would agree with me, that he is the finest teacher the country is blessed with. And not only that, he has inspired so many youngsters around him. My hearty congratulations to Sarath, presented excellently, and the Dr. Abir Goyal and Dr. Neeraj, showing extreme degree of knowledge and in dissecting the case. My congratulations to both of them. And I'm always jealous of Dr. Asta. She's an asset to any department, sir. And the literature review she did was fabulous. And I am sure that any resident who attended this, who has seen the rhythmical movement synchronizing, the convergent, retraction, nystagmus synchronizing with the facial movements, would never miss the diagnosis of Whipple's in his life. It's once in a lifetime experience for every resident. And I'm happy that the neurology secrets is day by day, it's going rising standards, and Sir has set the bar very high. Now, Professor Veklal sir has set the bar very high, and the next team should try to scale it. It's going to be difficult for any other team in the country to scale his peak. My sincere thanks to my inspiration, Professor Sudhir Shah, for giving us this wonderful time, and my thanks to Arun Chadda, Rahul and Heli for their beautiful background work. I thank every one of the residents who attended this, the entire group of the panelists, every one of them, thank you. I wish to remind you that we will be back on June 25th, Friday, with a fresh case from Stanley Medical College, Chennai. Thank you. Thank you for your attention. Thank you.
Many thanks, sir, and everyone.
Yes, sir.
Many
Thank
thanks to
you.
Sudhir, sir, Lakshmi, sir, and
Arun
Lal, sir.
Chadda, thank you. Arun
Thank
Chadda,
you.
would you like to say something?
Yes, sir. Thank you, sir. It's really great that we are at the end of the 11th session of Secrets of Neurology web series. Turned out to be very successful. I, Arun Chadda, Senior General Manager on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence. It's audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to thank our Honorable Course Director, Dr. Lakshmi Narasimhan sir, and Dr. Sudhir Shah sir for designing such a fantastic web series on Secrets of Neurology, which will be very helpful to all the DM and DNB students. And I would like to thank our young neurologists, Dr. Sharath, as well as Dr. Abir Goyal, for presenting the excellent and unique case. Further to this, I would like to thank the entire PGI Chandigarh team, Dr. Neeraj Bilani sir, as well as Dr. Astha ma'am, for explaining the procedure of this unique case. And in last, Dr. Vivek Lal sir, the HOD Neurology PGI Chandigarh, has given the excellent expert comments for such a unique case with fabulous presentation. The entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's been a pleasure being with all of you today. Thank you all for your patience, and I wish you a very good night now, with a promise that next, on 25th June, we will meet yet with another most awaited next session of Secrets of Neurology. Till then, stay safe and take care. Thank you. Thank you, sir. Thank you very much.
Thank you very much.
Thank you, sir. Thank you, ma'am.
Many thanks. Thank you.
Thank you,
Thank you,
everyone.
sir.
Good evening, sir.
Vivek Lal and Astha, be ready with another case after a couple of months.
Okay, we'll be ready. Don't worry.
Sir,
Thank you.
Asta is your, sir, Asta, Neeraj and Goyal are all your assets, sir.
Yeah, they're all assets. They are all assets. You see what happens, Lakshmi, that you have to groom these assets.
That's it. You have done that, sir. You have done that.
You have
See,
to groom these
inspiration-
assets. It's not easy. It's not easy. These days,
Yes.
you see what is happening is there is a decline in raw material. Now, when there is a decline in raw material, if you want them to become brands, you really have to work hard on them. You understand?
Yes, sir.
You know, that's how it is. But
I
nevertheless,
wish-
I'm glad. See, our place is known for clinical neurology. I tell my students, we are not research experts. We are simple people. We are grounded people. And I'm happy to say our methods are purely clinical and oriented towards patient care. And when you are purely oriented towards patient care, you do something unique for these patients, you know.
Sir, you have saved this patient, sir. You say so fatal. It's a fatal disease.
Yes,
And
yes,
irreversible changes, you have saved him.
yes,
2
yes,
weeks. World has shown 2 years of delay in
yes,
diagnosis. You
yes,
have made it
yes.
through.
This,
Sir, you
I
are-
think in less than
Sir, you are
10 days,
always
we
an
had the
inspiration.
diagnosis
You are always
and
an
the patient is recovered in 1 month.
Yes, sir. And the video, follow-up video,
Yes.
nothing is there. I saw his eyes are become better.
Normal.
Everything almost near normal.
Yes.
I think this is the happiness of clinical neurology.
Yes, yes.
You nail it and then hit it the right weapon.
Yes.
And you are so happy.
That's what I'm saying. I mean, this is what I say, turning gravity on its head. I mean, this is what I call satisfying recovery, complete resolution.
Sir,
You know?
I wish I spent some time with you.
Oh, come on, Lakshmi.
I always
You'll be coming
I
over.
always thought
Come
of
on.
spending some time under your.
No, Lakshmi, you're most welcome. Lakshmi, look. No, Lakshmi.
The
Please.
few hours I spent with you in Shine is the greatest moment for me, sir. I always
Thank you.
enjoy your presence.
Thank you, sir.
Thank you, sir.
Bye.
Good night.
Good night.
Master, good night, Dr. Goyal and everybody, my best wishes. Thank you. Bye.
Good
Thank
night,
you,
sir.
sir.
Thank
Whole
you.
team requires applaud. Yeah.
Thank you, sir.
All right, done.